Hello, everybody. It's Mrs. Bartels. I'm going to get you going on chapter 32. It is about the eye, the ear, and speaking. And it also has a little bit of chapter 8 in it for the anatomy of the eye and ear. Okay, so I'm going to click onto my morning class. I'm going to go over to my materials tab. And then from there, I'm going to go down to module 4. And I'm going to click on chapter 32's folder, which is the green folder. And right inside it, you will see, this is my class. I'm going to set the other class stuff like that too. You'll see what we call lecture materials. And if you click on that, there'll be images. This is the eye and ear image labeled with some notes on it that we'll be doing. And this is the PowerPoint. Okay, so the first thing I'm going to start with is the PowerPoint. Okay, so I'm going to open it up. Chapter 32's PowerPoints and lecture notes. So you want to have your book open to page 458. Okay, so chapter 32. Here we go. Hold on. Skip over all this. So the sense organs. Chapter 32 starts out talking about the sense organs. The sense organs include our sights, hearing, taste, smell, and touch. Okay. The sense organs basically receive messages from the environment, the things around us, and then tell our brain what is going on. Okay. We have nerve endings in our skin, taste buds in our tongue to help do this. The nasal cavity, the nose helps us with the smelling. Your nose and tongue are connected, and that will influence your smell, influences your ability to taste as well. So they kind of go together. It's like when you smell somebody baking a home baked apple pie or like brownies, that kind of stimulates you to want to eat those brownies if you like the way that they smell. Okay, and bad things you do not want to eat, things that smell bad. Hearing, speech, and vision is where we're going to go. So hearing, speech, and vision, without them, it is very difficult to communicate, learn, or even move about in the environments. They're important so people can take care of themselves, they can work, they can communicate, and they can live a healthy life. You need to be able to see to do things. You need to be able to see to drive. You need to be able to hear to drive. Okay, and you need to be able to speak in order to communicate. So they're all very important. Many people had some degrees of vision loss. And vision loss can be from the different reasons listed here: birth defects, accidents, or infections. Also, disease or aging. Again, remember, some people can be born with, meaning birth defects, they're born with hearing problems. They could have had an accident. We see this a lot sometimes with people who are in the war, people who are in the army and military service, or police officers because of the explosions and the guns. Infection, if you get a really bad infection, especially in your inner ear, you could have hearing loss. And also balance problems. Diseases can cause it, and aging, as we age, our hearing becomes a little more difficult. So the ear has the functions of hearing and balance. So not only does it help us hear, it also helps us balance this inner part over here. So this is called the outer ear, all this here. This pink stuff is called the middle ear. And then when we get into the canals and further, this is the inner ear. The inner ear is responsible for balance. The outer ear is responsible for getting the sounds in so we hear things, okay? So the outer ear collects sound waves and directs them inward towards the middle ear. So the outer ear, all of this, collects the sounds and brings it into the pink area called the middle area, okay? The outer and middle area are separated by a tympanic membrane. So outer, as soon as you get here to this green circle, it looks like a circle, that is your tympanic membrane. It's also known as the eardrum, okay? And then on the inner ear, you have the stapes, the inks, and the malleus, which are your bones. And in the middle ear, you have that. And then further in is the inner ear, okay? So again, the outer ear collects the waves and directs them towards the middle ear so we can start hearing, okay? And you know you're hitting the middle ear when you hit the tympanic membrane, which is also called your eardrum. The middle ear Once the sound comes through here and hits this tympanic membrane and gets into here, into the pink areas, the middle ear amplifies, makes the sound louder, and transfers the sounds into the inner ear, which then connects to the brain. Okay. The inner ear has tiny hair cells within the inner ear and nerve impulses to the brain. So again, when the sound gets into here, it's going to transfer over to the brain. There's 3 semicircular canals involved with balance. So these guys that are in your inner ear help you stay balanced. Sometimes when people have an inner ear infection, they might have dizziness or what we call vertigo, or they might have ringing in the ear, and that affects their balance and how they walk. Sometimes they walk like they're drunk, or they fall a lot. So if you have an inner ear problem, your balance will be off. Okay. And then the waxy substance, the earwax that we have in our ear, is actually produced to protect the bones in the ear and the canals in the ear, and it's actually used as a protectant, kind of like a coating, and that is called cerulean. Okay. So ear disorders. The first one we're going to talk about, or ear diseases, is Meniere's disease. Meniere's disease is on page 458 of your book. In Meniere's, all that like anatomy of the book, of the ear is in chapter 8. Okay, so we just did a quick review of it. Meniere's disease, the infection or the disease of Meniere's, is found in chapter 32 on page 458. Okay. It's a common cause of permanent hearing loss. People that have Meniere's disease can have permanent hearing loss. What happens is the fluid in the ear is increased in the inner ear. So again, if it's the inner ear that is having problems, they're going to have balance problems. So fluid builds up on that inner ear. It happens quickly, and it can last from minutes to hours or even years. Symptoms include vertigo, where they feel dizzy because there's extra fluid in the inner ear, so they feel that dizziness. Tenuitis, where they have ringing in the ear, or pain in the affected ear. So whatever ear is affected by it, they might have pain or discomfort or pressure. When somebody has Meniere's disease, you have to think about their safety at all times. Again, they're not going to be able to, they're going to be dizzy. They're at risk for falls. You want to assist them walking. You don't want to be turning them side to side. You want to try to keep them steady, because the more you turn them, the worse the vertigo gets. You want to have them sit. You don't want to have them do a lot of activity. No sudden movements. Okay, so that's Meniere's disease. The next one that we're going to talk about is hearing loss. Hearing loss is on page 459 of your book. Hearing loss is not being able to hear the normal range of sounds associated with normal hearing. So it's not that you're deaf, you just have a hard time hearing. That is the start of hearing loss. The severe form of hearing loss is deafness, okay? But just the fact that you're having difficulty hearing, and it happens a lot as we age, that is hearing loss. Okay? If you can't hear normal sounds, you're going to have to strain to hear them. You're working at it a lot more than what a normal person would. Losses can be mild to severe. Deafness is hearing loss in which it is impossible for the person to understand speech through hearing alone. It is the most severe, make sure you know this, the most severe type of hearing loss. We have hearing loss in all age groups. I know people think only old people can't hear well. That is not true. There are kids who have hearing problems. There are kids who are deaf. There are kids who wear hearing aids. And there are the elderly that wear hearing aids. So every age group is affected by it. Sometimes people just have a temporary hearing loss, and it's because they had a buildup of wax. That wax in their ears aren't cleaned, or sometimes it can be from an infection too. And remember, deafness is the most severe form of hearing loss. Going on, we are going to talk about signs and symptoms of hearing loss, which is on page 459 in box 32.1. How do you know somebody might be having some hearing loss? Because people are like, "No, I'm fine. I can hear you." And you're like, then why do I have to keep repeating myself over and over? Or why do I have to say, I have to speak louder? Or why do I come in your house and it sounds like the TV is going to blow out the windows because you have it turned up so high? Or you say, I can't hear you on the phone, just come see me in person instead. Those are all signs that they're having hearing loss. So some things that you're going to see, they lean forward to hear you. They kind of lean in to get closer to you so they can hear you. They misinterpret or misunderstand what you say. They answer questions or respond to things that are inappropriate. It's like, that's not even what I asked, but they kind of make things up because they don't want you to know that they're having a hard time hearing. So sometimes their answers are completely inappropriate. It probably could be hearing loss. So you need to look into that. They turn towards you, or they cup the better ear toward the speaker. So if you're talking, they will turn their stronger ear towards you, or they might put like their hand over their ear to cup it, so it's like a tunnel so they could hear. The TV, the radio, and other sounds um, are extremely loud to the point that people who have normal hearing loss are like, turn that TV down when they walk in the house, turn down that radio. How can we help somebody that has hearing loss? How can we promote hearing? How can we communicate with them? How can we take care of them? The first thing you do is you need to gain their attention. Don't just come up from behind and touch them because they're not going to hear you coming. So you want to kind of be in front of them and maybe get their attention by raising your hand or kind of like thumbs up or, give them a little nod so they understand and always approach them from the front. It's a good idea to squat or sit at their level so they can hear you. You're close to their good ear and you're also making good eye contact and you're facing them because a lot of them can do lip reading or they can do better if they're looking at you and understand the words that are coming out of your mouth. If there's a lot of noise going on, like maybe you guys are out in the dining room and trays are being passed and a bunch of people are speaking and there's a lot of extra activity, extra noise going on, maybe you need to take them out into the hallway where it's more quiet to talk to them. Always speak in a normal tone. Yelling and screaming at a high pitch does not work. Many people with hearing loss have a hard time understanding children and women because our tone is higher than a man. So you want to kind of do normal tone, monotone. Don't be squeaky like Mickey Mouse or Minnie Mouse or, Donald Duck. You want to just be like simple, a deep tone, deep or smooth. Do not be like, hi, my name is Lori. I'm your nurse today. Instead, be like, hi, my name is Lori. I'm going to be your nurse today. Okay. Speak clearly and distinctly at a normal rate. And I already talked about how the higher pitches are hard for them. Do not shout at them. Some people that have hearing loss will tell you shouting is just making it worse. Okay. So again, that normal tone, being close to them, talking in their good ear, facing them are all good ideas. Hearing aids are on page, also on page 460 in box 32.2. There's some stuff that I already talked to you about. How you gain their attention, how do you position yourself. That's all measures to promote hearing. Okay. Hearing aids. The hearing aids are very, very expensive. Okay, these guys are not so pricey. These are usually the ones that public aid will pay for. These like little miracle ear ones that nobody knows you have them because they're so tiny and they're like microscopic and electronic and everything are very, very expensive. My mother-in-law has hearing aids that each one costs over $8,000. So she's like $20,000 of hearing aids because she doesn't like the people to know that she has them. She has the really tiny microscopic, like great ones. Okay, you have to understand with a hearing aid, it does not correct or restore or cure the problem. It does not cure or heal the problem. The hearing aid just makes sounds louder for them. Okay, they're very costly. And again, they have to be taken care of very carefully. So we're going to talk about that. But you need to understand hearing aids, if somebody has hearing loss, they have hearing loss. All that a hearing aid is going to do is help them. It's an aid, help them to hear by making things louder. It is not going to make the hearing loss go away. That's with them forever. Okay, there is no cure for that. So how to take care of a hearing aid. When your person's wearing a hearing aid during the night, during bedtime, during the day, make sure you take it out at bedtime and store it, turn it off because the batteries can restore or you'll be saving batteries by turning off at nighttime. When you take them out, make sure you put them in a safe place. They usually go in a container and they usually get handed to the nurse and a nurse keeps track of them. It depends on your patient though. Some patients like to keep their hearing aids in their top drawer. You need to read the care plan and know what the policy is at your facility, okay? But do not just take them out and look at how tiny they are. Do not just take them out and put them in a drawer. You need to put them in a container and then know where you're supposed to put them. Are you supposed to put them in a top drawer? Are you supposed to give them to the nurse? You have to know what the policy is where you work, okay? But they do come out at bedtime. They come out when they're napping. They cannot get wet. They can't be in extreme hot or cold weather. So they cannot wear them in the shower, okay? The reason why I take them off at bedtime too is if they lay with them in their ears, you'll hear the ringing. or like a hmm. You're like, whose hearing aid is in their ear? Okay, so take them out at bedtime. It gives them a chance to get cleaned. They're stored, and they also save battery time then. So make sure when they're not in use, you place them in a storage case. And it says the top drawer here, so that's what we're going to go with. But like I said, some facilities require that when you take them out, you give them to a nurse, and a nurse is responsible for them because, again, they're so costly to replace. If a person's wearing a hearing aid and they can't hear you, we got to figure out what's going on. It's called troubleshooting. What is going on here? First thing you want to do is they're like, it's not working. It's not working. I can't hear you. And they actually have it in their ear. Take it out of your ear and make sure it's on. Make sure the battery is positioned correctly. If those things are not working, because sometimes they put them in your ears, forget to turn them on. And you're like, here, and you turn it on. They're like, oh, okay. Or sometimes the battery is dead or the battery is not in correctly. So you're going to make sure it's on. You're going to make sure the battery is inserted. If that's not working, you could change the battery. And sometimes it just has to be cleaned. If those things do not work, you need to get a nurse, okay? And cleaning them is based on how the manufacturer directions is. It's usually just simply cleaning them with like a cloth. And sometimes you can use alcohol white sound, but again, you have to see what is allowed at your facility. But it's usually just cleaning with a soft cloth. You don't want to put them in water. You don't want to soak them or anything. Okay. So when somebody has hearing loss, they also have speech problems because, again, the ear brings the sounds into, receives the sounds, and the sounds then go to our mind, and our mind then, or our brain gets the impulses of sounds and reacts to it. So if we're not hearing correctly, we usually have speech problems too. So we need to hear good in order to have good speech. Hearing loss may result from slurred speech. So we may have, if somebody has hearing loss, they might have slurred speech. Words may be pronounced wrong because, again, they're not able to really process the sounds that are coming in, so they don't understand how to make the sounds coming out. Some persons have a monotone speech, or they drop word endings. They might say, I like to run. And when they want to say, an example would be like, I like to go running in the morning, but they might just say, I like to run. Okay, they forget to get the ing and the in. I'm running in morning in. So sometimes they're very monotone. So you might hear a slurred speech. You might hear a stuttered speech when they have hearing loss. You might hear words that are not pronounced correctly. You also might hear a very bland, like robot tone, like, hello, my name is Mark. I go to John F. Kennedy. I am in 8th grade. Okay, very like monotone, like robot-like. And sometimes it's really hard to understand them because they have this hearing loss and the speech is affected. There's a couple of speech disorders we're going to talk about. The first one is aphasia. It is on page 461 of your book, and there's different types of aphasia we're going to talk about. So aphasia is when they have total or partial loss of the ability to use or understand language. Okay, so aphasia, A means absent, aphasia means speaking. So they're having a hard time with language. Okay, parts of the brain that are responsible for language are damaged when a person has aphasia. It's usually from a stroke, brain injuries, brain infections. It can happen with dementia as well. And sometimes some brain cancers can cause it too. Okay, so we see this a lot with our stroke patients, especially, and we see it a lot in dementia. Okay, so you're going to see changes in their language and how they communicate. It's called aphasia, and it's usually related to these things. The brain, the part of the brain that's responsible for language, is not working correctly. There's different types of aphasia. The first one is expressive aphasia, which medically it's called Broca's aphasia. Expressive aphasia, the word expressive is really key here. They have difficulty expressing or sending out thoughts through speech or writing. So they know what they want to say, they just can't get it out correctly. Okay, so it's like they in their mind has the words, but like the words are stuck in there, they can't get them out. The person knows what they want to say, but they have a hard time speaking, spelling, counting, gesturing, or writing. Okay. Expressive aphasia is on page 461 of your book. Some things that you'll see with them is they might speak in one word or short sentences. They might say walk dog, means that's supposed to mean I will take the dog for a walk. or you take the dog for a walk. They might just say walk dog, and you're like, what are they wanting me to do? Because they're not going to give you the full sentence. They can't get it out, but they know that they're trying to tell you to walk the dog, but they might just say, instead of say, can you walk my dog? They'll say walk dog. Okay. Again, they can't get everything out. So they might omit words and speak in short sentences. They also might mix up words. Like if they want to go to the bathroom, they might say room bath instead of bathroom. Okay. Or they are going for a shower and you're walking them down to the shower room. When they get there, they might say room shower instead of shower room. Okay. So, and they get very frustrated with expressive. Again, expressive, like your emotions. They can get very frustrated. A lot of times they give outbursts of crying. And it's like you were perfectly fine talking to them and they just start crying uncontrollably, or they might swear at you. It's because they're frustrated and they don't know what to do and they can't get it out. Okay, receptive aphasia is different. It's Wernicke's is what the medical term is for it. What happens with them is they have difficulty understanding the language. So what you're saying to them is getting in, like you're talking to them, and when it enters into their mind, it gets all scrambled up. So, like, I might say, I want you to eat your French toast and drink your coffee. And they might respond to me by saying, okay, it's time to go to therapy. And you're like, I know, that's not what I told you. I just said, I want you to eat your French toast and drink your coffee. And then they'll respond because I'm saying it, it's getting in their mind and they're not understanding what I'm saying. So they're not understanding the words that are coming out of my mouth. So they're not getting they're not getting the message. Even though I'm saying, I want you to eat your French toast and drink your coffee. They might, and I'll say, do you understand? And they'll say, yes. Today we're going to church. And you're like, that is not what I said. Why is he saying that? Because they don't understand. They don't get the message that you're sending. Okay, so they have difficulty understanding language. They have trouble understanding what is said or written, and words do not make sense. There are great videos posted in Schoology under Module 4, Chapter 32, of people that have these aphasias. We'll watch them in class too, but if you're not in class, I suggest you watch the videos and you will understand these better. Okay. All right. Oops, sorry, guys. That's not what I'm so sorry. Okay. Communicating with a speech impaired person. So somebody has speech impairment, it's going to be hard for them to have long, drawn out conversations with you. You're not going to have deep, thoughtful conversations. You're going to keep them short and simple. You want to keep the environment calm and quiet, okay? Because too much going on makes it more difficult. They're already having a hard time getting words out, processing things, and speaking. So you don't want to put them in the middle of a concert and tell them to do it, or in the middle of a party, So keep the room calm, quiet environment. You understand that you have to repeat and don't get frustrated with them. Ask questions to which you know the answer. This helps you learn how the person speaks. Ask questions to which how that doesn't even make sense. I'm sorry, you guys. So you're going to ask them questions that you know are not too difficult for them to answer. Okay, you got to make it simple. Allow the person plenty of time to talk. Be patient. It takes them longer to get their thoughts together and get their thoughts out. Watch for their facial gestures. Watch for your facial expressions and gestures. Okay, watch what they're doing and also watch what you're putting out there, because you send different messages for your facial expressions, your gestures, and your body language. Okay, so yes, it's taking him 10 minutes to tell you something and you're thinking in your mind, I have 30 other things to do. Just spit it out, and you might be rolling your eyes, or you might be like walking towards the door like, yeah. That's very rude to them and it can frustrate them. So be aware of what you're doing with your body. And don't correct them. That's embarrassing and it's difficult. Okay, so if they say, if they say something and it sounds funny, don't be like, you can't use what you're trying to say. Maybe they say, we have some people do this with, they use the wrong words. Instead of saying they have to have vowel, they'll say the S word. I need to take a. Okay, you have to understand they didn't mean to curse at you or use the bad word. That is how they say vowel movement, okay? Because they can't remember vowel movement. So they might just say, I had to take a shit, okay? Or I had to take a poop, and they yell it out, and you're like, oh, okay, you need to go to the bathroom? Don't correct them. When they're saying that, it's because they don't know how to say it the correct way, okay? So you just want to understand, and you kind of have to learn how they communicate so you can communicate with them, okay? The eye is next. Okay. Eye disorders. So a little bit of our anatomy on the eye really quick. The eye is how we see. So it has receptors for vision. It is protected by the bones that are in our skull. So it kind of sits in our eye socket, and our skull has like a opening called the eye socket that it sits in. Okay, so it's protected by bones in the skull. The eyelid's also protected because when things come towards us, our eyelids shut. They protect us so foreign objects don't get in there. Our eyelashes protect us because they constantly make us blink. Okay, and tears protect you because they keep everything moist. There's 3 layers of the eye. There's the sclera. Okay, and we're going to talk about the layers too. So first, we're going to talk about the sclera is the white of the eye. Okay, so we're talking about the outside of your eye. The sclera, if you look in a mirror and look at your eye right now, it's the white part of your eye that you see in the mirror. Okay? The front part of it is called the cornea. So the front part is called the cornea. It is how light enters into the eye. Okay. The second layer is called the choroid. It contains your iris. Okay, so here, the first layer is the white of the eye. It has the cornea. So it's this white part right here. And it's called the sclera. It contains the cornea on it. Then when we go into the next part, you have your iris. That's what decides what the color your eye is. And then you have the pupil. Okay. So the color, so when you're looking in the mirror at your eye, the white of the eye is called the sclera. It has the cornea on the outside of it. And then when you look at your eye again, you'll see like my eyes are brown. That is my iris. And the middle of my eye is a black dot. That's my pupil. Okay, so that's what your eye looks like. When light enters through the cornea and hits the pupil will react. And it depends if it's a bright light or a dim light, what happens. And then we have the retina, okay, which is the next layer. So we have the outer layer, the inner layer, and then we have the middle layer and the inner layer. Okay, and when we get into the anatomy, now we'll get better at this. Okay. So the retina is the inner layer. It has the receptors for vision, and it connects to the optic nerve. Okay, that goes to the brain. So again, your outer layer is your cornea and the sclera. Okay. The middle layer is called the choroid. It has the iris and the pupil. And your inner has the retina and the optical nerve. Eye disorders. Vision loss occurs at all ages. There are, again, same thing as hearing loss. The very young and the very old, and everybody in between can have vision loss. The most severe form is blindness. It's the absence of sight. You can have mild to complete blindness. It just depends. So you can have mild loss to complete blindness. It just depends on how bad and what's going on. It can happen suddenly, like you wake up and you can't see, or it could be gradual, like progressively. Like I was born with bad eyes. I've had glasses since I was 3 years old, but every time I go back to the doctor to get my eyes examined, it seems like we're getting new prescriptions because as I age and as gradually as life goes on, my eyes are getting worse. It can be one or both eyes. Both my eyes are affected, but my left eye is worse than my right eye. Okay, so eye disorders, a cataract. So these are page 462. The cataract is when they have a clouding over their lens. They kind of look like, you could see like a gray spot. It kind of looks like their eyes are like this gray, like hazy thing. When they're looking and trying to see, it's like looking through a waterfall or like a shower. Everything is like kind of watery and blurry, like looking through a waterfall. Okay, so things are cloudy and blurry when they see. Colors are hard for them. Blues and purples are hard to make out. They kind of look the same. Colors are very faded. Okay. They have a hard time at nighttime with cataracts, and they're very sensitive to lights. The only treatment for cataract is surgery. So you need to understand It could be in one or both eyes. It's the cloudy blurriness like they're seeing through a waterfall, and surgery is the only treatment. Next one we're talking about is age-related macular degeneration. What happens with that one is imagine you're looking with your eyes and you cannot see in the middle of anything. So central vision is gone, but you can see alongside. So you can't see in the middle of what you're looking at, but you can see things alongside. It causes a blind spot in the center of vision in the middle of where you're looking. It could be on the onset is gradual and painless. It might just start where they're seeing a little black dot, but then it starts to get bigger as time goes on. It's the leading cause of blindness in people over the age of 60. Okay, so again, with cataracts, it's the cloud and the waterfall. With age-related macular degeneration, it's the blind spot in the middle of center vision. Diabetic retinopathy is when a diabetic has the blood vessels in the retina become damaged. It's the leading cause of blindness in diabetics. It usually affects both eyes. If the person does not control their diabetes, their blood pressure, and their cholesterol, they're very much at risk for getting this. Laser surgery does help. Okay, the next one is glaucoma. Glaucoma is a little bit different. So glaucoma, your vision, you could see in the middle, your central vision is perfectly fine, but you can't see things alongside you. Okay, so the peripheral vision's bad. You could see in the middle fine, but you can't see things to the side of you. So people with glaucoma probably shouldn't drive because should you be able, when you're driving, should you see forward as well as the cars on the left and right of you? Yes. So glaucoma is a really hard one because they don't see things coming from the side. They don't see cars coming. They don't see people approaching them. So again, vision loss with eventual blindness can occur. It causes damage to the optic nerve. It can be in one or both eyes. It could be gradual or onset. But you need to understand the peripheral vision is lost in this one. Okay, so if we go over again, the cataract is the waterfall, where it's a cloud. Age-related macular degeneration is the black dot they can't see in the middle. The center vision is gone. Glaucoma, they can't see on the sides. They can only see in the middle. So it's kind of like they're looking through a telescope all the time or looking through a tunnel. When somebody has eye disorders, how do we care for them? Well, first of all, make sure you set their room the way that they want it. If you're going into their home setting, do not move furniture around, do not change things because they learn where things are. So don't move their recliner and not tell them because they have learned their environment by touching, feeling, or even counting their steps. They know from the door to my recliner is 22 steps. So if you decide to move the recliner to a different room, and now it's 52 steps, he's not going to know that. So don't move furniture around in them. Keep the areas where they walk free of clutter. Okay. Leave things the way that they leave them. Make sure their call light, TV control, and everything they need is close by. Make sure you tell them where they are. Let the person do as much as possible. People that have visual problems can do things depending on what the extent of their visual problem is, and you want to keep them independent. Identify yourself always when you're entering the room. Do not just walk up on them and say hi. Knock at the door and announce yourself. Hi, it's Lori, your nurse. I'm coming in now. Do not just kind of like walk alongside them quietly and go hi and make them jump up and startle them. Okay? So announce yourself. Face them when you're speaking to them, even though they're impaired, visually impaired. I know it sounds crazy. Face them, because if they have total blindness, yes, they won't see you, but if they have just like blurred blindness, they might be able to make out who you are or see you. So make sure you face them. Tell them when you're leaving. They can't see you're leaving. Okay, so when you're all done with the care and you're, okay, here's your call light, Mr. Smith. Your TV control's right here alongside you on your right side of your bed, on your bedside table where you like it. I'm going to be leaving now. Okay, call me if you need anything. Don't just be like, here's your call light, here's your TV control, and leave. You walk out. They don't know you walked out. They can't see that you walked out. And they might call out to you and you're not there. Tell them you're leaving, guys. Face the person when you're speaking, guys, and give specific directions. When they first come into a facility and they have visual problems, you want to tell them, especially if they're blind, you want to tell them This is your room. It is the third door on the right, because they'll feel as they're walking down the hallway, they'll feel like handrail, door one, handrail, door two, handrail, door three. That's my room, because you told them it's your room. Okay. And then you want to take them into the door and tell them, this is your closet. Have them feel what the closet door feels like. This is your bathroom. And sometimes they count steps, like from the hallway door into my patient's room is 5 steps, and on the right is my bathroom. So you want to kind of walk it out with them, okay? Give me this. I'm sorry, you guys. There we go. So Braille is something they also use, depending on how blind they are or how much visual loss they have. They might use Braille, and especially a blind person use it. It's a touch reading or writing system that uses raised dots for each letter of the alphabet. You've probably seen Braille if you get into an elevator and you go to push a button. When you go to push the button, you could feel the button, but a blind person can't see to know which button is for floor number 1, 2, 3, or 4. So they have little raised dots next to the buttons. That's Braille. And if somebody's blind and they know how to use Braille, they'll know, when they feel with their finger, what they're feeling, what floor that is. Okay. There's a picture of Braille in your book on page 465. Okay. Another thing that they use sometimes when they're visually impaired is they might have a long white cane with a red tip, the blind man's cane. It's usually about 3 feet wide, 3 feet long, so they can kind of, get a surface of what's going on around them, what's in front of them, because they are tapping with the cane, so they don't walk into things or walk into people. So they might walk with a longer cane, or they might have a guide dog. You have to understand, if somebody has a therapy dog or a guide dog, I love dogs too, but don't go running up to the guide dog. Okay, the guide dog is trained to not respond to anybody, and the guide dog is not a pet. He is actually an aid. So you should be, oh my God, he's so cute. Can I pet your dog? He's a guide dog. Okay, so you don't do that. Eye disorders, eyeglasses and contact lenses can correct vision problems. So eyeglasses and contacts are on page 466 of your book. Make sure you read How to Care for Eyeglasses in the Caring for Eyeglasses box, and also the Blue Box Delegation Guidelines Corrective Lenses. Know what you're supposed to do if somebody has eyeglasses or contacts, and know about safety and comfort on page 466. So we're going to go over really quick. Eyeglasses. If they wear eyeglasses, it is your responsibility to make sure that they are on, and your responsibility to make sure they are off when they don't need them and safely stored. When you were handing somebody their eyeglasses, can you please look at them and make sure they're clean? They should be cleaned daily. So before you give them to somebody in the morning, you should have cleaned them. Follow the manufacturer's instructions. You can usually clean them with warm water and a soft cloth. Okay. Do not use paper towels on them. They can scratch. Don't use any cleaner on them unless the manufacturer says it's okay. The best way to do it is just run them under warm water and use like a soft washcloth to clean them, or sometimes a lens cloth if the patient has one. That is the best way. Paper and tissue, paper towels, tissue paper can actually leave scratches on them or leave residue on them. So don't use those. And clean in a circular motion. Do not go back and forth. Clean in a circular motion when you're cleaning them. Okay. And don't clean them just once a day. What if they're dirty at lunchtime? Clean them whenever they're dirty, at least once a day and whenever dirty. If they're not wearing them, you need to take them off. You need to fold them up and put them in the case so they are safe. Don't wrap them in paper towels. Don't wrap them in any kind of like the old washcloth, because somebody might grab that and dump it out. Same thing with hearing aids. Don't wrap them in paper towels, tissue, washcloths, or have them, sometimes the patients like to tuck their glasses or their hearing aids underneath their pillow because they're tired and they didn't want to, call and do the whole routine of putting them into the case. Make sure you are careful when you're taking off linens on a bed that you're looking for those hearing aids and glasses. Okay, like they get tired. They don't want to do the whole routine of putting them away, so they might just take them off and tuck them underneath their pillow, and they forget about them. And you come in to make the bed, and you strip the bed, and now you put the glasses in the washing machine the hearing aid in the washing machine. So be careful. Never touch the lenses when you're touching somebody's glasses. Always hold them by the sides of their frames and keep them stored in a top drawer safely. Okay, that is it, you guys. So what I'm going to do now is I'm going to run over to a different thing. The images here. I'm going to show you guys these really quick. These are from chapter 8. Okay, they'll help you do the images that you have to label for homework. That's part of the study guide, and will help you understand the anatomy a little bit better. So again, here's a picture of the eye, and I kind of went over with you. Your cornea is on the outside. Okay, the sclera is the white parts, and then your iris is the colored parts. You might have blue, green, brown, depends. The pupil is the black part in the middle that changes with lights. The eye socket is how it sits in the skull bone. The eyelids and the eyelashes help protect it. Okay, the sclera, again, is this whole white area. It's also out here. And then there is your optic nerve that goes to your brain. Okay. And then, I did it again. I'm so sorry, you guys. Next picture. It's just another picture of it, a color picture. And here, like I said, if you're looking in the mirror, the white is the sclera, the black is the pupil, the iris is the color of your eye. And here's your ear. Again, here's your outer ear. Okay, here's your middle ear. So again, the outer ear is up to the eardrum. Once we get to the eardrum or tympanic membrane, we hit the middle ear. And then when you get to the inner ear, you're going to have these canals and the tubes, the U tubes, which connect to the throat. And this guys connect to the brain. Okay, so that's your inner part. Because sometimes you might hear kids get their tonsillectomies and their ear tubes done because when they're having a lot of like ear infections or a lot of sore throats and tonsil problems, they'll do surgery on the tubes, the E tubes, as well as the tonsils, because the throat and the ear are connected. Okay. And then here's another picture of it showing you the outer ear. The middle ear is where your stapes, incus, malleus, incus, and stapes are. Those are your bones in your ear. They are very, very tiny and they break very easily. Here's your eardrum. Okay. If your eardrum gets ruptured, you could break one of these bones and you can have permanent hearing loss or temporary hearing loss. And then when we get into this area where all the canals are, this is the part that connects to the brain. So if you get damage in here, like an inner ear infection or a rupture or something, you might have that ringing in your ear or balance problems. Okay, so this is your inner ear, the canals, these things that look like a snail or like, it kind of looks like a snail. Okay, these are your middle ear where your bones are, and the eardrum is what makes the outer come the middle. You rupture your eardrum and you're getting into big, deep trouble. Okay, that's why I always say nothing smaller than your elbow goes in your ear. So those Q-tips that everybody likes to stick in your ear, not a good idea, because if you stick it too far or use too much pressure, boom, you could push through the eardrum and now you have a problem. The eardrum is like a little thin piece of tissue, but it's there to protect us. Okay, I think that is it, guys. Let me double check. Okay, we are done. Just go back really quick. Just show you one more thing. Because if you're remote learning, I always worry that you guys aren't getting everything. So I want to show you a couple more things, and then I'll be done. I promise. So like that was all the stuff I just did in the green folder that says lecture materials. Here's your study packet. It has a study guide as well as a picture of the eye and ear that you need to label and color. And here are the videos that I talked about hearing, vision, and speech. Make sure you watch these videos, whether remote or in class, watch them. Okay, and here's a quiz for you. That is it. We are done.